Hello, everyone. This is Dr. Brian Capra from Billing Precision. We have another great webinar. This one is really good. This is one I get a ton of questions about. It pertains to Medicare. On the webinar today, I have Dr. John Davila, chiropractor, graduated from Palmer College in 1994. I don't know if you know Dr. Davila, but if you don't, I mean, he speaks all over the place about compliance, whether it's Medicare or documentation. I mean, he's a very well-known speaker out there. Notably, I would say the most notable thing is when it pertains to the Medicare specifically is the Palmetto GBA situation that you worked on in 2001. And I'm not going to try to explain that. Doc, first, thank you for coming on. Do you want to just quick mention, talk about that a little bit, and then we'll kind of start getting into this thing. But thanks for being on.
Thanks, Brian. Yeah, sure. I was lucky enough to, at the time, be president of the South Carolina Chiropractic Association and was asked to rewrite South Carolina's policy on chiropractic payment. And I got a chance to do that and then serve on the Medicare board, the Care Advisory Committee, for about 3.5, 4 years. And during that time, not only did I get to write the policy with the help of the nurses, but also over the course of 3 or 4 years got to train them and work with them on cases to see exactly what it is that they look for and understand what it is that they do. And so, you know, my experience isn't necessarily book-related as much as it is true hands-on. So when we talk about things that I know nurses are looking for, it isn't because, you know, I read it somewhere. It's because I know them even to this day. I still know a bunch of them, and you know, got to deal with them specifically on this type of issue.
Okay, so I mean, yeah, I mean, I know just from talking to John regularly, it's just he brings up stuff. I've talked to many compliance experts. A lot of you know that a lot of our system has been built with the advice of many compliance experts, and it's rare that I find somebody that knows as much as John does off the top of the head. And I mean, really, John brings up things that I don't hear from anybody else. So I mean, he's, as far as I'm concerned, he's the man when it comes to, especially with this Medicare stuff. So let me go to the next slide here and just kind of get started. So what we're going to talk about today is documentation and the Office of the Inspector General and how the definition of medical necessity dictates the difference between care plans and treatment plans. That's a mouthful, but I think as we go on through the slides here, John will be able to kind of really help you. I mean, I get this all the time with the you know, with the initial onset date, the treatment date, and when do I use it? What happens when the patient comes back in with the same problem, and can I still bill for it? How often can I bill for it? Do I only get 12 visits? Can I do that more than, you know, is it a new injury? All those questions you have, I think, are going to be answered by this webinar, and I think that is so frequent of a question that I get, and I try to divert that question as often as I possibly can. But you know, John's the man when it comes to this. So, John, if you want to just go ahead and dive into that.
Sure. This whole course comes from a report from the Office of Inspector General. And the OIG is nothing more than the Medicare police. They audit Medicare and Medicare files and things like that from all kinds of different people, from physicians and hospitals all the way down to, oh gosh, they do Medicare carriers themselves and look at if not they spend things correctly, even states for that matter, and the way they handle, you know, child protective service money. And they do all these audits. And in 2009, they did a review on the back of a review that was done in 2005. And what they found was that the situation's not getting any better. And over the last few months, it's really dawned on me that after looking through course after course after course online of what everyone else is teaching, they're all trying to give their opinion on what's going on. And I decided to go through this and really look at trying to remove opinion from what people are needing or looking for, and then try and put in exactly what reviewers are asking for. And knowing the reviewers that I know and dealing with insurance carriers that I have in the past, I can kind of cut through what was written and be able to tell people, listen, this makes sense. This is what they're looking for. So this whole webinar is really about what they're asking for, what they found, and what the problems are, and then from there, what can we do to implement? So we're going to talk about things you can do right away to implement into your EMR, into your written notes, whatever it is that you're using, and then be able to make a difference as soon as you get done watching this. So when we get started, and the first thing is what the report is. And this report obviously written, like I said, in 2009, and this is about inappropriate Medicare payments for chiropractic services. And they went through all these files, and what they found was that we're not very good at documentation. And what they found were these issues here. These recommendations, or what they found on, was one, that carriers should review treatment episodes rather than individual claims to strengthen the ability of CERT. And CERT is the comprehensive error rate testing, and that's what they do. That's what Medicare carriers do. Not carriers, I'm sure, but that's what other review companies do, like Advanced Med. They look at a paid claim and they CERT, and they look at whether or not you had part on one data service. Well, the OIG, in their infinite wisdom, decided, well, if I just have part on one data service, does that tell me whether or not the patient was improving or not over the course of a long period of time? Well, they went back and found out that it doesn't, and their recommendation in this report was to look at a bunch of dates. And if you're getting reviews now, you're starting to see that they're asking for, let's say, June 6, 2010 as a data service, but they're also wanting 6 months prior to, and that comes from this report. The next thing they want to do is to make sure the claim was not paid unless documentation requirements are met. So it's important that as you go forward from 2011, from this date in April, that you look out and you say to yourself, hey, not only do I have medical necessity, but do I have everything that they're asking for? Because what I'm beginning to find from different people that do reviews is that they won't even look at medical necessity unless you have everything that's bullet pointed in Medicare's requirements. So you won't even get to the definition of medical necessity unless you have everything checklisted. Next thing is they want people to take, carriers to take appropriate action regarding all these errors, meaning if you have an error and they find it, they're going to want the money back. And also they want to enforce policies to prevent future payments. Now, of all these recommendations, the last one's the important one, because if we don't fix internally what's wrong, we're going to end up with carriers doing something that we don't want, which is to manually reduce the number of visits that we get. As of today, as of April of 2011, we get unlimited visits within Medicare. There's no 12-visit rule or anything like that. But unless we change and fix the errors that we're going to talk about in a few minutes, we're going to end up with a 12-visit maximum or a 24-visit maximum per year. The same way the physical therapist had the same problem a few years ago, and now they have a dollar maximum per year regardless of what happens. So we don't want that to happen to us. Now, these three, of all these four recommendations, the top three CMS implemented. The bottom one we haven't. So we still have a chance to fix everything. So as we go forward, what we have here is the error rate. So if we look at the error rate itself, okay, what we found was the maintenance error rate in all of these claims that they looked at was 36%, which means of all the claims that were sent in, 36% were maintenance care. That's amazing. And if we look at the next slide, it says codes that were visits that were miscoded, 18%. And then from there, we look at total errors, including documentation, upcoded, downcoded, all these different things. Of all the claims that were sent in, 67% contained an error. Now that means that 67% of all the claims that they sent in should never have been paid, which is amazing. Imagine every hoop that we jump through to get paid for a Medicare claim that you would say is lined with broken glass or daggers or flames or something like that. Of all every time we try to get a claim paid, 67 out of 100 of them should not have been paid, which is absolutely amazing. There's got to be a reason why. So what we found after looking at this, there's a bunch of reasons, and they're all based on documentation errors.
So John, can I quickly ask a question there? Are you saying that 67% of the care is not medically necessary, or are they not getting paid simply because of procedural reasons?
Well, and that's a great question, and the answer is, and this is my take on the answer. The answer is it's partly procedural, meaning you chose the wrong code, things like that. The other part is this. if you get into a room of 100 people, okay, and they all have cancer, and you say, okay, how many people here smoked? And 80% of 100, 80% and 80 of them out of 100 all smoked. And you would say, okay, well that means everyone who smokes gets cancer. That's not true. And that all would also mean that in the sample, everyone has cancer in our community. That's not the case. But what's happened is this. With poor documentation systems that don't help you, like Billing Precision does, to help you understand what a case should be, and we'll get into that later, unless you have some type of backup to tell you what you're doing and what your profile looks like, you end up making major, major documentation errors. And handwritten errors, unless the doctor understands exactly what it should be doing, are a major problem. Documentation where you dictate, unless you understand exactly where you are at all times within a case, creates a major, major problem. And because of that, if you look at the doctor's inability to even discuss what medical necessity is, they can't really even decide how to document a case unless they understand medical necessity. So if you take all that together, of course, everyone's going to have these documentation errors because they don't understand the reasoning behind it. So does it surprise me that all these claims should have not have been paid? The answer is, from a procedural standpoint, no, some of them shouldn't be paid. Obviously, there's an error in coding. But unless we really, really train the doctors, and this is my point about this particular course, unless we train them what they're looking for, doctors understand how to document it, therefore we make the error. But let me ask you this. Because I didn't document it correctly, does that mean the patient didn't need it? Either from a maintenance standpoint, meaning the patient needed the care anyway, or because I made other errors at the beginning of the case, and I could only prove so many even though the patient needed more, but I was able to document it because I made a bunch of errors at the beginning. Mm-hmm. And that's where the problem is. So is it really 67%? The answer is yes, but only because we don't know what they're looking for. And if we did, that number would be big time less. Does that make sense?
Yes, absolutely.
So my job here today is to tell you what they're missing. That way you can maximize their benefits, not by doing the 3-card money, let's change the code thing every couple weeks, but by really, really creating medical necessity and then doing one thing, which is proving your way out of it at the end to be able to create the need for another case later. And that's where the problem is. So if we look at documentation errors, it just makes sense. I mean, most people don't understand what a complete history is. And if we were to talk about that, there would be the need to do the OPQ or ST, but not for the current illness, which most people do, as you can see, is less for a complete description of current illness, but also for the past problems too. Meaning, if you had a 67-year-old patient who bent over to pick up socks and they blew out their lower back, did they hurt themselves today when they come in and you look at their x-rays and it looks like scrambled eggs? The answer is no. It didn't happen today. It happened before. So you've got to ask the patient what happened before. And all the questions you would ask about today, you need to ask about what happened last time. And most people don't get that. And that's one of the things I like about your system. You have the ability to ask that question about the current illness, meaning how did you hurt yourself today? And then also in the past problem, what did you do in the past? And you can ask those questions twice. And that's really, really important because obviously you can see it's missing here. But that's not necessarily our question today. We can look past that into the next part, which is a complete treatment plan. And as you can see, that's a major, major issue. And I think, to be honest with you, that is the problem that most, most signifies exactly where our problems are within chiropractic today. We don't understand the difference between a care plan and a treatment plan. Therefore, when we go to set up the care for a patient, we really don't get what the patient needs because we never really set it up correctly. And that's where the problem is. So as we go forward, you can see, obviously documentation on a daily basis really isn't the problem. So if I can, Brian, I want to tell you a quick story. I actually sat on a plane going out to speak at Parker, Vegas in January, and sitting next to me was Tiger Woods' coach, Butch Harmon. And what he said, I asked him, I said, what do you think the biggest problem is in golf? And he said, it's the first 6 inches. And I said, what do you mean the first 6 inches? He goes,